Good afternoon, everyone. So, I shall be presenting our findings in Coats disease in infants, toddlers, and preschoolers. So, as we're aware, Coats disease is an idiopathic retinal vasculopathy which presents with retinal telangiectasia, which may be accompanied by intraretinal, subretinal exudation, subretinal fluid, neovascular glaucoma, which can lead to irreversible blindness. So, it has been reported in studies, and what we also saw in our own analysis of cases, that younger the age of presentation, more severe is the disease. However, such studies are generally lacking, non-specific. So we conducted a retrospective review of our own cases of the previous 1 decade to study the stage of presentation, clinical features, and the treatment outcomes of patients diagnosed with Coats disease, which were aged less than 5 years at first presentation. The primary outcome was to see the baseline demographic features, treatment strategies, and the long-term outcomes, and then also to assess the factors which are associated with final visual outcome and associated with the enucleation. It was a retrospective observational hospital-based study and in which the visual behavior, visual acuity, as well as the comprehensive ocular examination records were assessed, and wherever required, records of examination under anesthesia, fundus photography, B-scan ultrasonography was also evaluated. So we identified 98 patients and divided our cohort into 3 subgroups. First were infants which are less than 1 year of age at presentation. Second were toddlers which are from the age of 1 to 3 at first presentation. And then preschoolers from the age of 3 to 5 years at presentation. We found that the most severe stage was seen in infants, in which the most common stage was stage 5. Amongst toddlers, the most common stage was stage 3B, that is total exudative retinal detachment. And this was the same amongst preschoolers. If you look at the clinical features, what we found was that features such as retinal telangiectasia and presence of exudation were similar across all the groups. However, advanced features such as neovascularization of the iris, neovascular glaucoma, and vitreous hemorrhage were higher amongst infants. Out of the 98 eyes, we decided to treat only 58 eyes, in which 6 eyes were treated with just laser or cryotherapy. 13 eyes were treated with cryo and or laser, along with the use of intravitreal agents such as anti-VEGF agents or intravitreal steroids. 22 eyes required surgical intervention, and this was either in the manner of external fluid drainage or a pars crenal lensectomy with vitrectomy or a scleral buckling procedure. After a mean follow-up of 4.6 years, what we found was that in 70% cases, the disease does not resolve, and almost in 77% of the eyes, the patient is legally blind, that is visual acuity is less than 20/400. This is a case where there was total retinal detachment was noted and external fluid drainage was performed along with cryo, laser, as well as intravitreal anti-VEGF agent. Finally, at the last follow-up, disease has subsided, however, visual acuity is still less than 20/400. This is another similar case in which despite multiple attempts at surgery, multiple sessions of cryo and laser, the disease does not subside. However, the patient is comfortable and does not develop a painful blind eye. So what we found was that the most common stage amongst infants was stage 5, and amongst toddlers and preschoolers was stage 3B. A significantly greater incidence of retinal detachment and enucleation is observed in infants, and the need for surgery has been shown to be in toddlers. Of the 14 eyes which did resolve completely, 9 had received intravitreal agents at the time of treatment, highlighting its role. Of the 22 eyes which underwent surgery, all had a visual acuity less than 20/400, and just 4 eyes showed complete resolution of the disease. However, none of these surgical cases required any further interventions such as IOP reduction measures or enucleation. Of the eyes which we had deemed to be which did not require treatment, all of them were quiescent and did not require any further intervention in the further years. Thus, what we concluded was that Coats disease in young patients appears to follow a bell-shaped progression, which requires intervention to be carefully timed. Treatment should be planned based on whether disease is either in a phase of progressive worsening or already has reached a point of no return, after which symptomatic treatment is our preferred modality. The strength of our study is the largest sample size of this age group in literature, and we follow standard documentation and have multi-specialty care with oncologists, pediatric ophthalmologists, and vitreoretinal specialists. And this has been conducted with the help of anti-VEGF agents as well as with the current era of microinvasive vitreoretinal surgery. However, it is a retrospective study. It is a hospital-based study which has a selective bias, and we do not have a population-based data for this disease. Thank you.
So it was a nice presentation. a simple question. You are getting all the patients in stage 5, right? Most of the patients. How are you going to prevent this? Like, we want them at early stage to come to us. So what measures you are taking at your institute so that the patients become aware, or like how you are going ahead?
Doctor, first of all, I mean, the most common stage was actually stage 3B. Amongst infants, it was stage 5. And the most common symptom that the parents reported was a presence of a white reflex or leukocoria. So the message would be that as much as possible at the time of universal examination, an eye examination should actually become part of a neonate's or an infant's examination protocol. And the community as well should be aware that any form of white reflex or strabismus requires immediate intervention or referral to an ophthalmologist.
See, white reflex is already stage 5, right?
Yes, doctor.
So I'm asking how you are going to motivate, how to motivate them for early examination so that the patient doesn't reach that stage. Yours is an Apex Institute, right?
Yes, doctor.
So measures taken by you, like Jalali madam, is just superb. So what you are going for that?
Actually, if you look at even at this point of time, the exact pathogenesis of Coats disease isn't known. So why infants present with leukocoria, and in fact, even amongst infancy, at what time they present, we still don't have an answer for that. So to give you a specific answer to this one measure will reduce formation of stage 5. At this point, we don't have that information.
Okay, any predetermining factor in the family history or something which can help you out?
No, there was actually no significant family history amongst these stage 5 cases.
So what is the significant family history you get in these cases? Any history?
Not really.
Okay.
You had 10% of patients who required enucleation.
Yes, doctor.
Yeah. So my question is, what risk factors did you see on examination that would, can tell you that this patient might be having a more propensity for getting an enucleation, and anything like that came out through your study?
Younger age of presentation, and as we found out, if it's already presented with a painful blind eye, it will require enucleation. If it presents at a stage of total detachment and you intervene and provide surgery, even if visual acuity does not improve or worsens, enucleation will not be required. None of our surgery cases required enucleation. They do not require transclear photocoagulation, IOP drop, AGMs, nothing of the sort. So the method to prevent it would be early intervention at whatever stage it comes. If it is already a painless blind eye, it is better to let it be just observed, because they actually do not progress to a painful blind eye after that.